Let's discuss on porphyrias. Porphyrias are actually a group of inborn errors of metabolism associated with the biosynthesis of heme. So these are metabolic disorders of heme synthesis characterized by increased excretion of porphyrin rings and porphyrin precursors like ELA and porphobilinogen. Porphyrias can be of two types, inherited and acquired. Inherited can be of hepatic and erythropoietic type. Then acquired category may be due to the renal failure, liver cirrhosis, tumors, and toxicity by the metals, toxic metals like lead, mercury, and arsenic. All porphyrias are autosomal dominant disorders except the congenital erythropoietic porphyria, that is the autosomal recessive. So it is very easy to remember all types except for congenital erythropoietic porphyria, which is autosomal recessive. Porphyria in general are not associated with anemia. So this is the heme synthetic pathway. So enzymes concerned with the pathway, and there can be the various defects depending upon the type of enzyme deficient or defective. So it starts from the first step, that is the glycine and succinyl coenzyme A, which converts up into the ELA, and the enzyme is ELA synthase. So defect, this is the key enzyme of the pathway, and defective gene lead to pyridoxine responsive sideroblastic anemia, and administration of porphyrogenic drugs depletes the heme. So feedback inhibition on LRs is removed in this particular disorder. And this in turn leads to excessive production of heme intermediates, causing the neurological porphyrias. Porphyrin precursors and porphyrin in urine and feces are normal. And definitive diagnosis is by demonstration of mutation in erythroid LR synthase. Then second disorder is LR dehydratase enzyme, and this condition is very, very rare. Differential diagnosis can be done with that of tyrosinemia type 1 and lead poisoning. So characteristic features are quite similar to those of acute intermittent porphyria. The neurological manifestation and acute abdominal pain. The third most important disorder, that is due to the deficiency of enzyme PBG deaminase, porphobilinogen deaminase. So it's mentioned here. This is an hepatic disorder. The enzyme is PBG deaminase or uroporphyrinogen 1 synthase, the same enzyme. There are two names for the same enzyme. Then it is associated with abdominal pain and neuropsychiatric symptoms. Then third is the uroporphyrinogen decarboxylase, and defect in this enzyme leads to porphyria cutanea tarda, which is most common type of disorder, and it is associated with photosensitivity because below the uroporphyrinogen synthase, like from this onward, there is a synthesis of porphyrin ring, and above this enzyme PBG deaminase, there is no synthesis of, in any of the precursor, there is no synthesis of porphyrin ring. Porphyrin ring is an extensive alternate single double bond system which is very much sensitive to light. So that's how, because there is no porphyrin ring in the precursor above the uroporphyrinogen, so there is no photosensitivity in concerned disorder. But below uroporphyrinogen onwards, there is a photosensitivity because the porphyrin ring in all the intermediate is present. So this porphyria cutanea tardia is also another hepatic type of porphyria, and the enzyme is uroporphyrinogen decarboxylase or decarboxylase enzyme, and it is associated with photosensitivity, and there is a marked lesion in the skin because of exposure to light. There is a lot of damage to lysosome, and that leads to lesions in the skin. Then next is the this hereditary corporoporphyria. This is due to the defect in the enzyme coproporphyrinogen oxidase. It is also associated with abdominal pain, photosensitivity, and neuropsychiatric symptoms. The next is protoporphyrinogen oxidase. Deficiency of this enzyme will lead to porphyria variegata, and that is associated with abdominal pain, photosensitivity, and neuropsychiatric symptoms. The next is the enzyme heme synthase or ferrocatalase enzyme, and that leads to hereditary porphyria. And this hereditary porphyria is also associated with marked photosensitivity. Then in the photosensitivity is there. Then one more defect, that is due to the uroporphyrinogen 3 co-synthase. It lies here, 3 co-synthase enzyme, and that leads to congenital erythropoietic porphyria. So that is associated with photosensitivity, increased hemolysis, bloody urine comes out, and then there is a fluorescent, red fluorescent teeth. So there is an erythrodontia is very marked in the patient suffering from congenital erythropoietic porphyria. So two types, congenital erythropoietic porphyria and protoporphyria, they are of erythropoietic type, and rest acute intermittent porphyria, cutonia tarda, hereditary coproporphyria, and variegata porphyria are all hepatic type. Then have more detailed account of acute intermittent porphyria, as it is most common type hepatic disorder. So it is autosomal dominant trait, defect in the enzyme PBG deaminase or uroporphyrinogen 1 synthase. The two names for the one and only one enzyme. It is characterized by increased level of ELA and PBG in the blood and urine. So urine gets darkened on exposure to air due to the photooxidation of PBG to porphobilin. Then there is no photosensitivity because there is no porphyrin ring is formed in the precursors. Then acute abdominal pain is very marked, and neuropsychiatric symptoms due to the accumulation of PBG in ELA. There is a decreased activity of tryptophan firelase due to the depleted heme level resulting in accumulation of tryptophan and serotonin. And nerve conduction is also affected due to the severe accumulation of PBG and ELA. So lab diagnosis can be done on the basis of estimating the increased level of PBG and ELA in urine. Then treatment lies on patient should be given the hematin or heme, and there should be avoidance of phenobarbital, barbiturate, and anticonvulsant drug, because all these drugs lead to the stimulation of cytochrome P450 enzyme. So they will precipitate or increase the AIP symptoms. Then second most common disorder is porphyria cutanea tarda. That is the cutaneous hepatic porphyria. Alcohol overconsumption or iron overload will increase the condition. It is an autosomal dominant defect in uroporphyrinogen decarboxylase enzyme is there. It is a most common type of porphyria, and it is associated with the excretion of uroporphyrin 1 and 3. So porphyrin rings are very much present in all the intermediates. Then cutaneous photosensitivity is there, leads to itching and burning of skin when exposed to light. And liver exhibit fluorescence due to high concentration of accumulated porphyrins. And these skin lesions are due to the defect in due to the mass damage of lysosome and leakage of lysosomal enzymes. Diagnosis of porphyrin to demonstrate the porphyrins, the UV fluorescence is the best technique. The presence of porphyrin precursor in urine is detected by Ehrlich's test. When urine is observed under UV light, porphyrin, if present, will emit a strong red fluorescence. Treatment of porphyrias can be done by giving infusion of hematine. Then antioxidant vitamins can be given to remove the oxidative stress and oxidant species. Then use of sunscreens and avoidance of cytochrome P450 inducing drugs. There are a lot of anticonvulsant drugs and barbiturates.